Okay, in this video we're going to look at the lower respiratory tract. So we'll look at the lungs, we'll look at the pleura and the thorax, we'll look at all the air, the conducting zone, the bronchi, bronchioles, alveoli, talk a bit about respiratory immunity, the blood vessels to the lungs, the nerves that innervate the lungs, and then say a bit about the embryologic development of the lungs. So we already discussed the upper respiratory tract in the last video, so I'm not going to go into the trachea, but remember this is the connecting point between the nasopharynx, the larynx, and then it's the tube that connects to the lungs. So the lungs are located in the chest or the thorax on either side of the heart, inside the rib cage. The wall of the thorax is actually formed by the spinal column, the ribs, and the breastbone, the sternum on the front, and then intercostal muscles. So that's actually the wall of the thorax, and inside that are the heart and lungs. The thorax is really divided into two spaces, and this inner space here, which is pretty filled up with the heart and these tissues, is called the mediastinum. So that kind of divides the thorax into two. Now the lungs are surrounded by a tissue, the pleura, and the pleura really has two membranes. There is one layer of the pleura which is actually attached directly to the wall of the thoracic cavity. So the ribs and the muscles there, that's called the parietal pleura. And then there is a visceral pleura which attaches to the surface of the lung itself. And then between the two, there's a little cavity, the pleural cavity. And you can kind of see that here. That's the pleural cavity there, this space. And there's a fluid, a lubricating fluid, the pleural fluid, which fills that. And this is going to be important because jumping a little ahead to how inspiration happens, how we get the lungs filled with air, is the diaphragm, which is normally in a resting position like that, kind of bowed up. In inspiration is going to contract, and it's going to essentially, there is the pleura attached also, the parietal pleura is attached to the diaphragm, and that's going to pull down the parietal pleura. But the parietal pleura, although it's not directly attached to the visceral pleura, this little pleural cavity actually has a negative vacuum space. It actually has a little bit of a space that has less than atmospheric pressure in it. And as a result, the pulling down the parietal pleura is going to pull down the visceral pleura, and that's going to pull the lung down. That's going to open up the lung cavity, the lung space, and that's going to draw air into the alveoli, the air sacs. So really the airflow itself is kind of a passive process. The only thing active is the contraction of the diaphragm. And then expiration is easy. The diaphragm just relaxes and the air goes out. Now, as we'll see, under active breathing, like you're exercising and so forth, we actually engage more muscles to help pull the ribs up and to help pull the diaphragm down with our abdominal muscles. And those are called accessory muscles of breathing. But under resting conditions, it's pretty much just the diaphragm that we use for breathing. But because we pull the parietal pleura with that, it actually pulls the visceral pleura, and that opens up the lungs. It's very important to maintain that intrapleural pressure to properly expand the thorax. And unfortunately, we can get some pleural diseases which can affect that. So one would be actually pleuritis, also known as pleurisy. And that's usually as with like pneumonia or other lung infections. We get inflammation of the pleura, and that creates really sharp stitching pains on inspiration. So that's pleurisy. The pleura is better innervated than the lungs, so we can actually localize pain a lot better when the pleura is involved. And then pneumothorax, that can happen for a variety of reasons, but basically that is air that gets sucked into that pleural cavity. And unfortunately what happens there is that collapses that pressure, and that can lead to a collapse of the lung itself. So the lung will collapse. The lung is very delicately positioned with the pressures here, and so if you get an increase of pressure in the pleural cavity, that will collapse the lung. And that can happen if you insert a needle that breaks through the parietal pleura and introduces air into that space. It can happen spontaneously. You can have these little what are called blebs in the lung that open up, and that creates a pneumothorax. It can happen from trauma like a rib fracture, A lot of different things can cause that, and we'll talk about the differentials later. But that's something to know about, especially as an acupuncturist, especially up in the upper areas of the lung here, at what's called the apex of the lung. In these regions, the lungs are very close to the surface of the skin, so needling up here can be very dangerous, and that could potentially induce a pneumothorax. Another thing that can happen is fluid can build up in that pleural space, and that's called pleural effusion. And that can happen for a number of reasons again, often infection, like pneumonia, but it can also happen from cancer metastases from different organs, like the prostate or whatnot, can metastasize to the pleura, and that can create effusion. And that fluid builds up, again, compresses and collapses the lungs, and that actually needs to be drained out. And that could be done, we'll talk about how that's done through different methods. And then you can get tumors in the pleura, and the most common one is mesothelioma. That's when we connect with asbestos. So that's one of the reasons why we're worried about breathing in asbestos. The asbestos particles are silica. They actually migrate over decades from your lungs to the pleura. Then they set up a local inflammation there. Immune cells migrate in, and that chronic inflammation causes the pleural cells to mutate, become dysplastic, and they can develop into mesothelioma. All right, so that's the pleura surrounding the lungs. The lungs technically start from the trachea at the carina. We have the two primary air tubes. They're called the primary bronchi, and a singular bronchus, but plural bronchi. So the right bronchus leads into the right lung, which again is on the patient's right, so that's right. And then the left bronchus into the left lung, and that's left. We, of course, have the mediastinum separating them, and then the heart and pericardium are found in here as well. The right lung has 3 lobes, versus the left lung only has 2, and that's because we can say the heart really occupies the space of where that 3rd lobe should be. So the right lung, 3 lobes, left lung, 2. And the lobes are formed by the infolding of the pleura. So really the visceral pleura goes in, plunges inward, and it creates the different lobes, separates them. What's going to be important is that the primary bronchus, again, 1 for each lung, is going to branch into, in the right lung, into 3 secondary bronchi. Each secondary bronchus supplies a single lobe. And then the left, there's two secondary bronchi, and each one supplies a lobe of the lung. The lungs are conical in shape. The apex is the top region, as I just mentioned here, and that extends past the top of the first rib. So if you feel your first rib and go a little bit above, so the lungs go right in there. So again, there's no bone there. You put a needle through there, it's a very thin layer of skin and muscle, and then you're right into the lungs. And the base is what rests on the diaphragm down here. So that's the base of the lungs. The hilum is the root of the lungs, and that's where the bronchi enter. And along with that, we also have arteries. So we have the pulmonary artery and vein coming from the heart. And then we have lymphatic vessels and nerves. They all enter and exit at the hilum. And there are bronchopulmonary lymph nodes that are also found all throughout the hilum region. And those would be lymph nodes that become potentially cancerous with the spread of lung cancers and so forth. All right, so that's the basic structure of the lungs. One thing I will say with the bronchi, I think it'll be coming up here, but I'll just say it here as well. If you look at the slope of the bronchi, the right bronchus actually has a steeper slope. Maybe I'll draw it in blue here. Steeper slope than the left bronchus. And that's because the heart is here, kind of presses upward. Why this is important is that children or people, anybody that aspirates a thing like a button or a Lego or something like that, it'll tend to fall down the trachea and go into the right lung because it's a steeper curve, and typically doesn't go into the left lung. There is actually, just like we have with the digestive system, the capacity to put a scope in there called an endoscope. We have something called a bronchoscope that can go down, and you can actually go down into the bronchi. The bronchoscope can both visualize. A lot of bronchoscopes are equipped also with little forceps and things that can actually take things out of the lungs. Some of them have little vacuum suction so they can pull mucus out of the bronchi. And they can also be equipped with equipment to take a biopsy of the airways as well. So bronchoscope is one of our ways of useful for both diagnosis and treatment of lung conditions. So let's start with the bronchi here. Again, singular bronchus. These are part of the conducting zone. There's no gas exchange that happens here. They have respiratory epithelium. They're made of smooth muscle and they have cartilage rings. So all the bronchi, primary, secondary, tertiary, have cartilage rings. If you kind of look at the structure here, so down in this picture, you can see the trachea. Here's the carina. Here's the primary bronchus, breaking into secondary bronchi, and then going into tertiary bronchi, and then even smaller bronchi, and then eventually bronchioles. By the time you get to bronchioles, the cartilage disappears. So the cartilage starts to become more plate-like as you go further down. But down in the bronchioles, it's just smooth muscle. And that's why the bronchioles are actually a lot more susceptible to they can undergo bronchoconstriction and so forth, and these are the ones that are involved in bronchoconstriction and asthma, for example. Interestingly, if you pick up lungs, like if you look at sheep's lungs or human lungs, they're actually really hard. They're crunchy. You'd think the lungs being an airy organ would be kind of light and fluffy, but it's actually very hard, which is why in many traditions, traditional medicines, they actually relate the lungs to an earth or metal organ. This is not really an air organ. In fact, if we look at the primary element associated with earth, it's carbon. And one of the main functions of the lungs is to regulate not oxygen, but carbon dioxide levels. The kidneys actually are more associated with regulating oxygen levels. So the lungs are more carbon dioxide. But you kind of notice from their nature, they're very earthy, very kind of dense and hard and even crunchy if you kind of press down on them. And a lot of that's because of the cartilage. All right, so we looked at the primary bronchi already. One primary bronchus for each lung, branches off at the carina at T5, enters the hilum of the lung. The right primary bronchus going into the right lung is wider and more vertical than the left, and so this is where those aspirated objects tend to fall down, down, down into the right bronchus. And the left primary bronchus goes into the left lung. There is, for each lobe of the lung, then a secondary bronchus, and so the right lung has 3, left lung has 2. And then there's a further division, and these are called bronchopulmonary segments. There's 8 segments in the left lung, 10 in the right, and each segment has its own blood supply, nerve supply, and lymph supply. And they're separated from the rest of the lung by connective tissue. So it's like a little compartment of a lobe is a bronchopulmonary segment, and each segment is fed by a tertiary bronchus. Now, the importance of that is that if there's a lung cancer or trauma to the lungs, the surgeon can actually resect a bronchopulmonary segment, and the rest of the lung is fine. So it leaves the rest of the lung intact and properly functioning. Then there are subsegmental bronchi. So these are further divisions of the tertiary bronchi. They divide really into 3 branchings. There's a 4th order, 5th order, 6th order segmental branches, and then they lead into the bronchioles. So you can see the little bronchioles down here. Those are the tertiary bronchi, the subsegmental bronchi. And the bronchioles then become terminal bronchioles. Those become respiratory bronchioles, alveolar ducts, alveolar sacs, and then we get the actual air sacs, alveoli at the end. So pretty much from the respiratory bronchioles down, this is going to be part of the gas exchange zone. So it's no longer part of the conducting zone. It's actually the respiratory zone of the lung. The significance of the bronchi clinically would be bronchitis, would be acute or chronic inflammation of the bronchi. Acute is usually from infection. Chronic is more like chronic bronchitis associated with cigarette smoking, etc. Bronchiectasis is a thickened bronchial wall, usually from chronic infections and irritation. Aspiration, again, we talked about the food aspiration or the foreign body aspiration. And then asthma involves the bronchioles, but it can involve the bronchi as well, creating bronchial inflammation and constriction. So those are some bronchial disorders we'll be reviewing later. Going downward from those subsegmental bronchi, now we have the bronchioles. So they're smaller branches of the bronchial airways. There's no cartilage anymore, and there are fewer and fewer goblet cells, and they're only about 1 millimeter in diameter. the mucosa changes as well. So it goes from that columnar ciliated respiratory epithelium to ciliated cuboidal epithelium, more cube-like, squared, not so much rectangular. And again, this is all resting on the basement membrane. And again, the goblet cells become less numerous. The important thing is the bronchioles have a lot of smooth muscle, no cartilage, but smooth muscle. So if you look down at this picture here, here's a normal bronchiole, and you see the thick wall here, that's muscle. And again, this is not skeletal muscle, but smooth muscle. And smooth muscle is under the regulation of your autonomic nervous system, and it's also susceptible to hormone stimulation of different sorts. And the important branches of the nervous system here are the sympathetic nervous system. And this is going to release, when activated, the neurotransmitters norepinephrine. Your adrenal medulla, which sits on top of your kidneys, secretes epinephrine into the blood. And both epi and norepi bind to what are called beta-2 adrenergic receptors. This is a receptor for norepi and epi, and they're found on the bronchial smooth muscle. And when they're stimulated, they lead to bronchodilation. A lot of people get that confused. When you think of sympathetic stress, everything constricts down. But in the lungs, it's the opposite. And you can think of your sympathetic nervous system really supporting your heart and lungs to get you through a stressor, to get you through an activity. So we need more air, we need more oxygen exchange, more CO2 removal during stress. So your airways actually open, bronchodilate. Your blood vessels in the lungs dilate. That's called vasodilation. So you get more gas exchange into the capillaries. And then you get decreased mucus production. So basically the sympathetics support breathing. They support the whole breathing process. Now, you've probably seen people take their inhalers for asthma. There's several different types. Some of them are steroids, but for the acute acting bronchodilators, there's two different types. They are called short-acting bronchodilators, SABAs, short-acting they're actually beta agonists, short-acting beta agonists. They are beta-2 agonists that bind basically to that receptor, and they cause all those effects, bronchodilation, etc. So they're kind of mimicking your sympathetic nervous system. And it's interesting that, a major source of the catecholamines is from your adrenal medulla. So, this interesting idea in Chinese medicine, we talk about treating asthma and lung disorders, many of them through the kidneys. And that's actually what we're doing biomedically as well. You're mimicking the adrenal medulla secretion with your beta-2 agonist, and that is opening up the airways. Now, different alkaloids like ephedrine, which is found in herbs like mahuang, ephedra. Ephedrine also binds to beta-2, so it does the same thing. Unfortunately, ephedrine also binds to beta-1s, which are on the heart, and that causes increased heart rate and increased heart constriction. It can also increase blood pressure. It also binds to alpha-1 receptors, which are on blood vessels, and that also increases blood pressure. So these are unwanted side effects of ephedrine. SABA is what we call, it's selective to beta-2. So it doesn't bind to beta-1. There's some cross-reactivity in some people because the receptors are very similar. But generally, SABAs affect beta-2 more. And there's a new class of medication called LABAs, long-acting beta-2 agonists. They also activate that, but their half-life is a lot longer. And they're typically used with steroids, corticosteroids, glucocorticoids, to decrease the inflammation in asthma. In fact, that's the other inhaler is usually glucocorticoids, and they come from your adrenal cortex, again, from the kidney system. So biomedically, it's interesting. We treat asthma from a kidney approach, and a lot of people don't realize that we're actually doing that. So that's the sympathetic system. Assists the breathing, opens the airways, and so forth. The parasympathetic system, paradoxically, shuts down breathing. So if you ask what it does, it really decreases, it causes bronchoconstriction, vasoconstriction of the blood vessels, and increases mucus production. This is why a lot of asthmatics, for example, at night, their sympathetics go offline, the parasympathetics kick on. they actually get asthma attacks at night. It makes more mucus in their lungs. Interestingly, after a meal, your parasympathetics also kick up, and that's another time that people often have asthma attacks, is after eating. So that shows you that parasympathetic balance. Now, when you use acupuncture and you needle, for example, the shoe points on the back, which correlate to the sympathetic chain ganglia, one theory is you're actually increasing output in the sympathetic nervous system, and that's what's causing all these beneficial effects of bronchodilation, vasodilation, decreased mucus production on the lungs. All right, so that is the autonomics in the smooth muscle in the lung. Now, the end of the conducting zone really ends in the terminal bronchioles, and that marks the beginning of the respiratory zone. Each terminal bronchiole is about 0.5 millimeter or less in diameter, and it supplies air to what's called a pulmonary lobule or respiratory lobule. So the respiratory lobule is, you kind of see these little fluffy white things. That's the respiratory lobule, and that's where gas exchange is essentially happening. And that's part of the respiratory zone. So they deliver the terminal bronchioles down to what's called the lung acinus. So we can think of the terminal bronchiole and all the little lobules, the little acini is part of the pulmonary lobule. I know it's a little confusing. The respiratory bronchiole is the first part of that. So that's going to be inside, not shown in this picture, a little bronchiole that actually has gas exchange happening in it. But that's going to lead into an alveolar duct. We'll look at that in the next slide here. Alveolar sacs and then the alveoli themselves, which are at this point just a single layer of squamous epithelium in the alveolar sacs. Now, the importance of bronchi is you can develop, just like we had bronchitis, inflammation of the bronchi, you can develop bronchiolitis, which is inflammation of the bronchioles. Now, one thing I will say is that infection and inflammation are not always the same thing. So an area can be inflamed but not infected. Usually when we have infection, there's inflammation. So we can actually have bronchiolitis and bronchitis that is not from infection, that's from more of a chronic inflammatory process. So not all bronchiolitis is from infection, but that's the most common thing. And so we can get really narrowing of the airways that can create a lot of difficulty breathing and so forth, especially with different respiratory tract infections. So respiratory syncytial virus is a common one with kids, and they can develop bronchiolitis. Asthma also affects the bronchioles. And then something that we're seeing more of is bronchiolitis obliterans, where you get destruction of the bronchioles from a massive inflammatory process. And that's known as popcorn lung because it was first seen in popcorn workers. So people making the artificial butters for popcorn, when it volatilizes, it gets in the lungs and it actually can cause severe damage in the bronchioles. But unfortunately, where we're now seeing it is with vaping. And so we have a number of deaths now of teens, sudden deaths where they go into respiratory failure. And it's because their alveoli are completely destroyed from the inflammatory process in the vaping. Vaping, when the vaping liquid is put into that pen, it's heated to very, very high temperatures. And at those temperatures, a lot of commonly inert elements like vitamin E, which is often used as an antioxidant preservative in those things, becomes toxic. And you also get heavy metals coming off of the pen itself. They become volatilized in there. And it really damages the bronchioles. And so we're seeing bronchiolitis obliterans now in people vaping. And so there's kind of a cry in the sort of call out in the medical community to sort of alert people about this possibility. All right, so that's the bronchioles. Now we get to the alveoli. And a single is alveolus. These are the basic units of respiration and the site of gas exchange in the lungs. There's about 300 million alveoli in each lung, so we can think of these as the functional units of the lung. Each has a diameter that's very tiny, 200 to 500 micrometers. They consist of a single layer of squamous epithelium, and around that alveolar membrane is a network of capillaries. So if you look down at this picture in the bottom right-hand corner, you can see this is actually the lumen of the alveolus here, the airspace. Here is a single layer of cells. You can see the purple is the nucleus of the cell, and these cells are very flat. And I'll talk about the different types of cells here in just a moment. And here is the next alveolus right next to it with its cells. And in between you have a very thin layer of connective tissue. And then you have capillary. So here's a capillary. It has its own thin layer of epithelium. And so really between the, let's say this is oxygen here, oxygen to get into the body has to diffuse across the wall of the alveolus, across the wall of the capillary. See if I can blow this up here a little bit. Across the wall of the capillary, and then attaches to hemoglobin inside the red cell. Carbon dioxide, we'll talk about that a little bit more complicated, but basically it's going to form, most of it's actually dissolved as carbonic acid in the blood, but then it reforms as carbon dioxide and water, and the carbon dioxide passes out this way. So these are gases that can easily diffuse through these thin membranes, but that's a very thin membrane. That's why any inflammation in the alveoli can be devastating, and the one acute condition we have to be really worried about is pneumonia. In pneumonia, this whole alveolar space becomes filled with mucus and pus, and that's going to affect gas exchange, and so people literally will suffocate because they're not getting that adequate gas exchange. So that's one, but any damage to the alveolus, for example, acute inhalation of different toxic dust, if you're in a house fire, accumulation of that smoke can cause damage in the alveolus. It sets up immune cells migrate in to kind of clean up the mess, but they damage in the process these cells, and we can actually get acute bleeding into the alveolar space. That's a very thin wall there. In fact, nowhere in the body is there this thin of a barrier between the outer world, this is really still outer world here, and your inner world. It's basically just two little cell layers thick there. And that's in the digestive tract, there's a much thicker barrier. Your skin, of course. So in the lungs, we are directly connected with the earth element in a way. We're directly connected with the outer world, the physical element through that. All right, so that's the alveolar membrane in a little bit more detail. Again, we'll look at the cells here in just a moment. If you unfold the whole surface area of the alveoli, notice that the alveoli are kind of puckered, looks like little grapes. And this increases the surface area. And if you stretch it all out, it's about 70 square meters, which is the size of a tennis court. And this is unique to mammals. In fact, mammals have the highest sort of surface area and density in the alveoli. Of course, in fish and amphibians, we have gills, which are more on the outside. So really the capillary system is just on the outside. And then that begins to internalize. The gill system becomes a lung system in the birds and the reptiles. And then in mammals, we have this very developed respiratory system. Interestingly, the lungs, we'll look at the embryology here shortly, but the lungs really don't complete their development until around the age of 7 or 8. So we still continue to grow alveoli until our 7th or 8th year. Around the time you change your teeth is when you also stop developing new alveoli. The pulmonary lobule I mentioned is the site of gas exchange, and that's where the terminal bronchioles become respiratory bronchioles, and then each respiratory bronchiole gives rise to 2 to about a dozen alveolar ducts, and then each alveolar duct opens up into a few alveolar spaces, and then we have the alveoli themselves. And there are little pores that are found between adjacent alveoli. Draw the blue here. Look at the right-hand corner there. And that's going to allow gas exchange between alveoli. Now, the problem of chronic lung conditions like emphysema, so chronic bronchitis affects the bronchioles, and the bronchi, versus emphysema actually damages the alveoli. The alveoli are kept in this puckered form because their walls are very rich in, that's the blue part here, this connective tissue is very rich in elastin. And that keeps everything puckered and nice, but unfortunately in emphysema, you lose the elastin. and you essentially get a flattening out. So all those bubbles, so if you have this really bubbly kind of alveolus, becomes just a sac like that. And so you lose surface area. And so you lose the ability for adequate gas exchange. So people with emphysema often have to breathe very rapid. That's called tachypnea. And they just to keep up oxygenation so that they are constantly reperfusing. So this is an unfortunate thing that happens when you lose that elasticity there. Now, the most common reason for that is chronic cigarette smoking, but actually there's a genetic reason as well, and we'll talk about that also. So that is the basic structure of the alveolus. Again, the membrane is the site of the gas exchange, very thin, about 0.2 to 0.6 micrometers. And there's several layers. So you have an epithelial layer. That's what I pointed out in this picture here. That's the epithelial layer. We have the interstitial space in blue, and that has connective tissue like the elastin. There's nerves in there. There's some lymphatic vessels. There is a basement membrane both on the epithelial layer as well as a basement membrane, I'll draw it in green here, around the capillary. And then the capillary endothelium itself, and then the blood inside. So those are all the different barriers between the outer world of the lungs here and our inner world of the blood. Now, one other layer I should talk about here is the lungs secrete, the alveoli secrete it's not a mucus layer, it's a fluid layer that coats the inside of the alveolus. That's called surfactant. And surfactant is important because number one, it has an immune role. It's kind of the final barrier to prevent things from getting into the lungs. But another role of surfactant is it decreases the surface tension of water. So if you think of like surface tension, if you have a glass, that forms that kind of surface on it. In fact, water striders kind of walk on that surface. If you put detergent like soap on top of that layer, it actually collapses the surface tension. So if there happens to be a water strider on that, it would actually sink. So your surface tension actually creates a film on the top of the surface of water. Well, interestingly, water inside here also creates surface tension on the inside of the alveolus. In fact, that surface tension is so strong and the alveolar wall is so delicate that if left to its own devices, the surface tension would collapse the lungs, the alveoli. You wouldn't be able to breathe. In fact, we don't really develop that surfactant until just a couple months before birth. And so premature babies, often one of the problems is they don't have surfactant and they can't breathe. So surfactant actually works like detergent. It actually collapses it. It lowers the surface tension so that the alveoli, the air sacs, stay open. Once we start secreting surfactant, later in pregnancy, then the air sacs can stay open. But surfactant is very important, and from a more Chinese medicine angle, we can think of surfactant as really part of the lung yin. In fact, we suspect that a lot of people with after lung injuries or a chronic infection, or maybe an acute infection, then you have this chronic dry cough and whatnot, that might be associated with a lack of mucus, potentially surfactant. So the mucus would be in the airways and the bronchi and bronchioles, and the surfactant in the alveoli, that this would be a lung, what we call yin deficiency. That moisturizing aspect would not be there anymore. All right, so that's pulmonary surfactant. In terms of the cells forming the wall of the alveolus, there's several different types. So the most common is what's called a type 1 alveolar cell, or a pneumocyte. And this is simple squamous epithelium, and it's the main cell involved in gas exchange. So again, if we look at the lung over here, here's an alveolus. Here, showing type 1 pneumocyte. Here's the capillary. And so gas exchange happens across those membranes. There's another type of cell. It's a little thicker. And you can kind of see it in the pictures up here. This is the thicker cell here. That's called a type 2 pneumocyte, or a septal cell. These are more cuboidal epithelial, and they secrete surfactant. So this is what lowers that surface tension on the inside of the alveolar wall. So type 2 pneumocytes, the septal cell, secrete surfactant. And then finally, there are macrophages found here. I believe this picture shows a macrophage kind of hanging out there in the alveolus. The macrophages also are known as dust cells because they actually accumulate dust particles, coal particles, soot, things like that. And they are part of what's called the reticuloendothelial system. These are your macrophages found all throughout the body that are involved in innate immune defense. So the liver has its own resident macrophages called Kupffer cells. The skin has it, they're called histiocytes, and so forth. So these are the resident macrophages of the lungs. And then there are fibroblasts, which are found more in the deeper connective tissue. So this is probably showing a fibroblast down here. The fibroblasts are involved, they secrete the connective tissue. In chronic inflammation, unfortunately, the local immune cytokines will tell them to oversecrete collagen. And so these are the ones that can actually start oversecreting collagen, and then we get lung fibrosis. And so that's going to be the hallmark of a lot of chronic lung diseases is fibrotic lungs. And as you can imagine, that's going to impact the ability of the alveoli to function properly and so forth. Now, there are several normal airway defenses. So both involve the innate and adaptive immune systems. I just want to kind of review some of them because there's so much focus, for example, on bugs, the flu virus and this virus and that virus and killing the viruses, but very few talk about the lung immunity. And I just want to point out we have very strong immune defenses here that are constantly active. So in the upper airways, we have salivary IgA that gets washed into the pharynx. Remember, IgA is a surface antibody. We have proteases, lysosomes. There are growth inhibitors promoted. They're produced by normal flora. Fibronectin coats the mucosa and further inhibits microbe adherence. In the lower airways, we have innate defenses like cough, the mucociliary clearance we talked about, airway angulation like in the bronchi, alveolar macrophages, those dust cells I just talked about, and surfactant, all are non-specific defenses. And then we have specific T cell defenses, and that can secrete IgA, IgG via activated B cells. Then we have in the mucosa, all the way down the trachea, all the way down the airways, we have MALT, mucosa-associated lymphatic tissue. And we have that very richly in the tonsils, we have it in the adenoids, and collections of lymphocytes in the trachea and bronchi. In the bronchi especially, we have a special type of MALT that's called BALT, and that is the bronchus-associated lymphoid tissue. And that secretes large amounts of that IgA into the respiratory mucus, and that's what forms what we call the immune paint. So immune paint is IgA with all these other antimicrobial peptides together with secretory IgA. So very important for proper immune defenses. It probably wouldn't surprise you to know that chronic elevated cortisol and high sympathetic stress decreases IgA secretion. Very common finding, and so we're going to be more susceptible both to respiratory and to gut illnesses. Then we have our respiratory flora and microbiome, which is going to inhibit, as I mentioned, any pathogenic bacteria, helps maintain proper nutrition of the respiratory epithelium, and we might see disturbances of that in chronic lung diseases. It's still an active area of research. So we know that different things can damage the normal flora, so different systemic illnesses, malnutrition, antibiotics is a big one, being in hospitals, nursing homes, but then weakened T cell, B cell responses, different things specifically like cigarette smoking, and then any sort of intubation are going to weaken those defenses. But I find the neuroendocrine system is probably the most important. So again, looking at stress hormones, melatonin, interestingly, is important for maintaining normal respiratory health, and so poor sleep could be a problem. We know that thyroid issues can contribute to poor lung immunity, hypothyroidism. Having lowered from the adrenal glands, the adrenal cortex secretes cortisol, but also secretes another hormone called DHEA, which if we were to say, what is kidney qi in Chinese medicine, this is a big candidate right here. DHEA has a very protective role on proper lung immunity and proper lung health. And unfortunately, with chronic stress and aging, we start getting less and less DHEA and more cortisol. And so we get less of those protective effects. We can think of cortisol as having a very catabolic effect versus DHEA is more anabolic. So that is other areas that can damage the respiratory immunity. Now I just want to say a little bit about the arteries and veins and nerves of the lungs. So the entire cardiac output flows through the lungs from the right heart to the left heart. That's about 5 liters per minute at rest in the average adult. The lungs have a dual blood supply. So we have first the pulmonary arteries. Now, this is the only artery in the body that actually carries deoxygenated blood. So it's carrying blood from the right heart, and it is carrying all that deoxygenated blood to the lungs. It's going to be oxygenated. It's going to go to the left side of the heart via the pulmonary veins. So pulmonary veins carry oxygenated blood to the left side of the heart. So I know that's a little confusing, but that's the only place in the body where we have the arteries and veins different in the sense that usually arteries carry oxygenated blood, but not in the case of the lungs. And then the pulmonary arteries further branch and they go down, basically follow the bronchi and go down into each bronchopulmonary segment and then further and further. So eventually they break into the capillaries, and each of those capillaries surrounds the individual alveoli for gas exchange. Now, there is a second arterial system which provides fresh oxygenated blood to the lungs, and those are the bronchial arteries, and they originate from the descending thoracic aorta, and they supply the lung around the hilum and the visceral pleura. So the hilum gets more oxygen, and the visceral pleura also is oxygenated with the bronchial arteries. And so this can provide some oxygenation there. Now, there is a blood pressure in the pulmonary tree, and that's called the pulmonary blood pressure, and that's much lower than systemic pressure. So if you look at the systemic arterial pressure, it's around 95 millimeters of mercury. In the pulmonary system, it's only 15. Unfortunately, different conditions, like for example, failure of the left heart and heart failure, can lead to a backup of blood in the lungs, and that can increase the blood pressure, causing pulmonary hypertension. And that can create all sorts of problems of basically a fusion of fluid into the lungs, and that can cause effusion down in the alveoli and so forth. So that can be quite a concern. Another thing that can happen in the arterial system is we can develop, let's say down in the veins in your leg, a thrombus. Thrombus is a blood clot inside of a vessel. That's called a deep vein thrombosis in the legs. But they can develop actually anywhere. But the most common site in this case is going to be down the legs. That thrombus can break off, forming what's called an embolus, and that can travel up the venous system through the right heart, get into the pulmonary artery, and then as the blood vessels get smaller and smaller in the divisions in the lungs, it can become trapped there. And that embolus can block circulation downstream. So essentially that area of the lung no longer receives blood flow. And that can cause that area of the lung to die. And that's called a pulmonary embolus, or PE. And that can cause all sorts of symptoms. Small ones go unnoticed, but larger ones can actually cause massive circulatory collapse to the lungs. And that can actually be fatal. And so we'll talk about that in the context of deep vein thrombosis when we talk about the cardiovascular system. The pulmonary veins, again, carry the oxygenated blood away from the lungs back to the left heart, to the left atrium. And so that's the venous system. And then there are lymphatics that drain the lungs into the thoracic duct. That's the venous system, and that drains into the left subclavian vein. And that goes back to the heart. So that's the arterial system, the venous system, and lymphatic system. Now, one further thing I'll say about the arterial system is, by bringing the oxygenation into the lungs, all that nutrition, we can say this is an aspect of the lung yang. So in Chinese medicine, yang really refers to metabolic forces. And so lung yang would be more the tissue metabolism from the arterial system. The veins would really carry away waste products and things like that. And so that's part of the lung yin. So we talk about lung yang deficiency. That could relate to the arterial system, lung yin more to the venous system. We can also think of the lymphatics as part of the lung yin as well. Now we have the innervation. We've already spoken about the lungs, the sympathetic, parasympathetic. Again, remember parasympathetics, the ones that are innervate the lungs, arise from the vagus nerve, which arises from the brainstem. And then the vagus nerves, if they pass down, there's two of them on either side of the spine. As they pass down, they innervate, in this case, the lungs. And parasympathetic stimulation causes bronchoconstriction, vasoconstriction, increased mucus production. The sympathetics arise from your thoracic spine, from T1 down to L2. And they're going to go usually synapse onto the sympathetic chain, into ganglia there, and then a secondary postganglionic neuron will go out, in this case, to the lungs. So that's going to be the sympathetic flow, and that's going to all increase bronchodilation, vasodilation, and decrease mucus production, supporting breathing. Now, the breathing apparatus is regulated in the brainstem by what's called the respiratory center, and that actually is going to send signals. So that's actually two centers. One is in the medulla. This is the dorsal and ventral respiratory groups of neurons. And then in the pons, there is a second center here. This is the apneustic and pneumotaxic area, also known together as the pontine respiratory group. So these four sets actually of ganglia all regulate breathing. They're getting inputs from all sorts of different areas. So there are chemoreceptors sensing the amount of oxygen and carbon dioxide. What we do know is that the primary signal for stimulating breathing is going to be a rise in the blood levels of carbon dioxide, not oxygen. At very high, very low levels of oxygen, that could trigger breathing, but usually inspiration is going to be triggered by elevated levels of carbon dioxide. That's called hypercapnia. So that's going to be, CO2 is the main driver of inspiration and respiration in general. So when these neurons are triggered to fire, they send out nerve impulses down the vagus nerve, down the spinal cord to the phrenic nerve. And the phrenic nerve, again, comes from C3 to C6, going to come out, and it's going to innervate the diaphragm. Now, some of the phrenic nerve fibers also innervate what are called the external intercostal muscles. These are muscles between the ribs. They're going to actually help lift the ribs while the diaphragm pulls down, and that's going to expand the chest cavity, and that's going to draw air into the lungs. There are also accessory muscles, and this would be in your abdominal wall, or along the side of the body, latissimus dorsi, your pectoralis muscles and whatnot. They'll all be activated when necessary for accessory breathing, and we'll talk about ventilation here in a little bit. And there are also internal intercostal muscles that fire. So that's the respiratory center and how it helps to integrate breathing here. So that's a little bit about the autonomic system, but then also the phrenic nerve and its innervation with the diaphragm in the brainstem breathing centers. Finally, we'll look at pulmonary embryology here. So the gut tube, which begins in the third week of embryonic development after fertilization, is made of endoderm. That's one of your three primary germ layers, remember. And there's a little outpouching towards the mouth end of the gut tube that's going to pouch out, and that's actually going to form the respiratory epithelium. So the lung epithelium actually comes from the endoderm, same tissue that makes the endothelium of the gut, the epithelium of the gut. So that's why there's such a connection between lung and gut. And that's going to happen in the fourth week of development. You form a lung bud, you get two little side buds, and each one will form a lung. Now, this lung development is very susceptible to vitamin A deficiency, as well as lack of adrenal steroids like DHEA and cortisol. And so those are, even in adult life, I find very important hormones and vitamins for maintaining proper lung health. Interestingly, vitamin A from the diet mostly comes from beta carotene. And beta carotene is actually two vitamin A's really stuck together. And you actually need thyroid hormone to break that bond. So hypothyroidism can also contribute to lung issues here. So that is the general development. Now the lung goes through 4 stages of development. The first stage goes from weeks 5 to 17. It's called the pseudoglandular phase. And really the lungs, these lung buds look like glands. They're solid, they don't have hollow spaces, and looks kind of like intestines. Then there's a canicular phase where you basically hollow out those tubes, and we see a widening of the bronchi and the bronchioles, and the respiratory bronchioles start to develop. There's kind of an overlap of the glandular phase as well at this stage, but that goes up to about week 25. Then there's a terminal sac period, which occurs from week 24 to birth, and that's where we form the alveolar sacs, and these are the precursors to the alveoli. Surfactant begins to be secreted around week 26 onward, and so by the 7th month, there's limited respiration possible if the baby is born prematurely. Before that, if a baby is born, they have to actually use positive pressure oxygen, maybe use a lot of glucocorticoids, the steroids, to accelerate lung development. And then the alveolar period, this continues from up until the 8th year of life, and that's where we really develop our alveoli further, and we have full development of the lungs and the neurosensory aspect. So that's a little bit on lung embryology. So that covers it for the upper and the lower respiratory system. Our final thing is to look at some of the basics of pulmonary physiology, and then we're done with the lung anatomy and physiology section.